Have you ever walked into a doctor's office for a routine health checkup, believing it's the key to staying healthy and catching problems early, only to leave with a stack of confusing test results, unexpected anxiety, or even a referral for more invasive procedures you didn't need? If you're a woman over 70, this video is an absolute must-watch. I'm Dr. Emily Carter, and I'm here to pull back the curtain on the ugly truth about common health checkups that senior women are often told are essential but can cause more harm than good. From unnecessary PSA tests to risky full-body scans and over-frequent DEXA scans, I'm diving deep into why these tests might be leading you down a path of stress, medical bills, and even harmful interventions. Stick with me until the very end, because I'm not just exposing the problems. I'm sharing safer, smarter, and more effective alternatives that will empower you to take control of your health with confidence, precision, and peace of mind. Before we begin, I would appreciate it if you like this video. You can help me continue to spread the old age lesson. If you haven't subscribed yet, I recommend you subscribe and turn on the bell so you don't miss any videos. If you like this video, please comment number 1. If you don't like it, comment number 0 to let me know, so I can make a better video for you. Now let's get started. 1. Routine PSA testing, prostate-specific antigen, for women. Let's dive into the specifics of prostate-specific antigen, PSA, testing and why it has no place in routine medical care for women. PSA testing is a blood test designed to measure levels of prostate-specific antigen, a protein produced exclusively by the prostate gland, which is found only in men. Since women do not have a prostate gland, ordering a PSA test for a woman is not just irrelevant. It's a medical oversight that can lead to confusion, unnecessary worry, and even inappropriate follow-up care. So why does this happen? In some cases, PSA testing is mistakenly included in a broad hormone or cancer screening panel ordered by a healthcare provider who may not have fully tailored the tests to the patient's sex, age, or specific health concerns. For example, a busy primary care provider might order a comprehensive blood panel that includes PSA alongside other markers like thyroid hormones or tumor markers, without realizing that PSA is irrelevant for women. In other instances, patients themselves may request PSA testing after hearing about it in the context of men's health, assuming it's a universal cancer screening tool. Miscommunication between patients and providers, or even clerical errors in lab orders, can also contribute to this mix-up. For senior women over 70, this kind of testing error is particularly problematic. Aging brings a natural increase in health concerns, and receiving a lab report with unfamiliar or irrelevant results like PSA levels can spark significant anxiety. Imagine opening a report filled with numbers that don't apply to your body. Numbers that might seem alarming simply because they're unfamiliar. This could lead to unnecessary consultations, additional testing, or even referrals to specialists for conditions that don't exist. Overtesting like this is not just a waste of time and money. It can contribute to a phenomenon known as the cascade of care, where one unnecessary test leads to a chain of follow-up procedures, each with its risks, costs, and emotional toll. For instance, a misinterpreted PSA result could prompt a doctor to order additional imaging or even a biopsy, procedures that carry risks like infections, bleeding, or false positives. In senior women, who may already be managing multiple health conditions or medications, these interventions can be particularly burdensome. Moreover, the financial impact of overtesting cannot be ignored. Medicare or private insurance may not fully cover tests deemed medically unnecessary, leaving patients with unexpected bills. What can you do? Always ask your healthcare provider to explain the purpose of every test they order. Questions like, "Why is this test necessary for me?" or "How will these results guide my treatment?" can help ensure that your care is precise and relevant. If PSA or another irrelevant test is proposed, don't hesitate to challenge it. Request clarification on how the test aligns with your specific health needs, symptoms, or risk factors. Empowering yourself with knowledge and advocating for tailored care can prevent unnecessary tests and keep your healthcare focused on what truly matters. 2. Routine full-body scans without symptoms. Full-body imaging scans, such as computed tomography, CT scans, or magnetic resonance imaging, MRI, are often marketed as cutting-edge tools for detecting hidden diseases before they become serious. The idea of a comprehensive checkup that peers inside every organ sounds appealing, especially for senior women over 70 who may worry about undiagnosed conditions. However, the reality is far less rosy. Routine full-body scans in the absence of specific symptoms often cause more harm than good, leading to overdiagnosis, unnecessary procedures, and significant emotional and physical stress. The primary issue with full body scans is their tendency to uncover incidental findings, small abnormalities like nodules, cysts, or calcifications that appear suspicious on imaging but are, in most cases, completely benign. For example, a full-body CT might reveal a tiny lung nodule, a benign liver cyst, or a small adrenal mass. These findings are common in older adults and often have no clinical significance, meaning they would never cause symptoms or affect your health. However, once detected, these findings often trigger a cascade of additional tests, such as follow-up imaging, biopsies, or even surgeries, all of which carry real risks. Biopsies, for instance, can lead to complications like infections, bleeding, or pain, while surgeries in older adults increase the risk of anesthesia-related issues or prolonged recovery times. Let's consider a real-world scenario. A 75-year-old woman with no symptoms undergoes a full-body CT scan as part of a preventive health package. The scan reveals a 5 mm lung nodule. Her doctor, cautious about missing a potential cancer, orders a biopsy, which requires sedation and carries a small risk of lung collapse. The biopsy confirms the nodule is benign, but the procedure causes weeks of discomfort and anxiety, not to mention medical bills and follow-up visits. This cycle of worry and intervention could have been avoided entirely if the scan hadn't been performed in the first place. Another concern with routine CT scans is radiation exposure. CT scans use ionizing radiation, which accumulates over time and may slightly increase the risk of developing cancer later in life. For senior women, who may already have a history of imaging tests, adding unnecessary radiation exposure is particularly unwise. MRIs, while free of radiation, are not without risks. They're expensive, time-consuming, and can still lead to incidental findings that spark the same cascade of follow-ups. The U.S. Preventive Services Task Force and other major medical organizations do not recommend routine full-body scans for asymptomatic individuals, regardless of age. Instead, targeted imaging, such as a mammogram for breast cancer screening or a colonoscopy for colorectal cancer screening, is far more effective and safer when guided by specific symptoms, risk factors, or evidence-based guidelines. For example, if you have a family history of lung cancer and a long history of smoking, a low-dose CT scan of the chest might be appropriate. But a full-body scan, just to be safe, is likely to do more harm than good. What can you do? If your doctor or a private imaging center suggests a full-body scan, ask for a clear explanation of why it's necessary and what specific conditions they're looking for. Discuss whether targeted tests, based on your symptoms or risk factors, would be a better approach. Prioritize evidence-based screenings, like mammograms or bone density scans, that are proven to benefit women your age. And be wary of direct-to-consumer imaging services that market full-body scans as preventive care. These are often profit-driven and may not align with your best interests. If you are still watching this video and finding these lessons useful, please comment number 1 below to let me know that you are still watching this video with me. Thank you for your valuable time. 3 DEXA scans are too frequent. Bone health is a critical concern for senior women, particularly after menopause, when declining estrogen levels accelerate bone loss and increase the risk of osteoporosis and fractures. The dual-energy X-ray absorptiometry DEXA scan is the gold standard for assessing bone mineral density, helping to identify women at risk for fractures and guiding treatment decisions. However, a common misconception among patients and even some healthcare providers is that DEXA scans need to be performed annually after age 70. In most cases, this is not only unnecessary but can also lead to overdiagnosis and overtreatment, with real consequences for your health and quality of life. The National Osteoporosis Foundation and other expert guidelines recommend DEXA scans every 2 years for women over 65, or longer if previous scans show stable bone density and there are no new risk factors, such as recent fractures, significant weight loss, or starting medications like corticosteroids that can weaken bones. For women over 70 with normal or mildly low bone density, osteopenia, and no other risk factors, scanning every 3 to 5 years may be sufficient. The rationale is simple. Bone density changes slowly, and frequent scanning rarely provides new information that would alter your treatment plan. So, why is overtesting with DEXA scans a problem? First, it can lead to overdiagnosis, where minor changes in bone density are flagged as significant, potentially labeling you with osteoporosis or osteopenia when no immediate action is needed. For example, a small decrease in bone density might not increase your fracture risk meaningfully, but the diagnosis alone can lead to prescriptions for medications like bisphosphonates, e.g., alendronate or zoledronic acid. These drugs, while effective for some, carry risks such as gastrointestinal irritation, rare jawbone problems, osteonecrosis, or atypical femur fractures with long-term use. Starting these medications prematurely or unnecessarily can expose you to side effects without clear benefits. Second, frequent DEXA scans can contribute to the medicalization of normal aging. Small fluctuations in bone density are common and don't always translate to real-world risks like fractures. Yet, seeing these numbers on a report can make you overly focused on your bones, leading to anxiety or a sense that your health is more fragile than it is. This psychological burden can detract from your overall well-being and distract from practical steps that truly protect your bones. Instead of relying on frequent scans, prioritize lifestyle measures that support bone health. Ensure adequate calcium, 1,200 mg daily from food and supplements, and vitamin D, 800 to 1,000 IU daily, or as advised by your doctor based on blood levels. Engage in weight-bearing exercises like walking, dancing, or light strength training, which stimulate bone formation and improve balance to prevent falls. Fall prevention is especially critical. Simple home modifications like removing loose rugs, installing grab bars, and ensuring good lighting can significantly reduce fracture risk. If you're on medications that affect balance or bone health, e.g., sedatives or corticosteroids, discuss alternatives with your doctor. What can you do? Before agreeing to a DEXA scan, ask your healthcare provider about the timing of your last scan and whether a new one is necessary based on your risk factors. If you've had a recent fracture, significant weight loss, or a change in medications, a scan might be warranted sooner. Otherwise, stick to the recommended interval of every 2 years or longer. Focus on lifestyle interventions and ask your doctor about tools like the FRAX score, which estimates your 10-year fracture risk based on factors like age, weight, and family history, to guide decisions about testing and treatment. 4 Pap smears after 70 without risk factors. Pap smears have been a cornerstone of women's health for decades, playing a critical role in the early detection and prevention of cervical cancer. By identifying abnormal cervical cells before they become cancerous, Pap smears have saved countless lives. However, as women age beyond 70, the necessity and benefits of routine Pap smears diminish significantly, particularly for those with a consistent history of normal results and no risk factors. Continuing these tests in low-risk women after this age can often lead to more harm than good, and understanding why requires a closer look at the science and the risks involved. The rationale for scaling back Pap smears after age 70 is rooted in both biology and clinical evidence. Cervical cancer is strongly linked to persistent infection with high-risk strains of human papillomavirus, HPV, a sexually transmitted virus that is typically acquired earlier in life. For women who have had normal Pap smears for many years and no history of cervical precancer or cancer, the likelihood of developing cervical cancer after age 70 is extremely low. This is because the body often clears HPV infections over time, and any cellular changes that might have occurred earlier in life are unlikely to progress to cancer in older age. Guidelines from organizations like the U.S. Preventive Services Task Force, USPSTF, and the American College of Obstetricians and Gynecologists, ACOG, recommend discontinuing routine Pap smears after age 65 or 70 for women with a history of normal results and no risk factors, such as a history of cervical precancer, HPV exposure, or immunosuppression, e.g., due to HIV or organ transplantation. So, why can continuing Pap smears after 70 be harmful? The issue lies in the potential for overdiagnosis and overtreatment. As women age, their cervical tissue becomes thinner and more fragile, which can lead to minor cellular abnormalities being detected on a Pap smear. These abnormalities are often benign and would never progress to cancer, especially given the slow-growing nature of cervical cancer. However, an abnormal result typically triggers a cascade of follow-up procedures, such as colposcopy, a procedure to closely examine the cervix, cervical biopsies, or even treatments like cryotherapy, cauterization, or loop electrosurgical excision procedure, LEP. These interventions carry significant risks for older women, including pain, bleeding, infection, and scarring. The healing process in older adults is slower due to reduced tissue elasticity and a weaker immune response, which amplifies these risks. For example, a biopsy or LEP can cause persistent discomfort or even lead to complications like cervical stenosis, where the cervical opening narrows, potentially causing issues with menstruation or future examinations. Beyond the physical risks, there's a significant emotional and psychological toll. Receiving an abnormal pap smear result can trigger anxiety and fear of cancer, even if follow-up tests show no serious issues. The waiting period for results, coupled with the stress of additional procedures, can be particularly burdensome for older women, who may already be managing other health concerns. Moreover, the financial cost of these follow-ups can add up quickly, especially for those on fixed incomes. The key to making an informed decision about pap smears after 70 is a personalized discussion with your healthcare provider. This conversation should focus on your risk factors, including your history of pap smear results, HPV testing, if applicable, sexual history, and any conditions that might increase your risk, such as smoking or a weakened immune system. If you're deemed low risk, meaning you've had consistently normal pap smears for at least 10 years and no recent risk factors, guidelines suggest it's safe to stop routine screening. Instead, you can redirect your focus to other preventive health measures, such as maintaining a healthy diet, staying physically active, and monitoring for symptoms like abnormal vaginal bleeding, which should prompt a visit to your doctor regardless of screening status. By avoiding unnecessary tests, you can minimize risks and prioritize your overall well-being. If you are still watching this video and finding these lessons useful, please comment number 2 below to let me know that you are still watching this video with me. Thank you for your valuable time. 5. Full lipid panels every visit. Cholesterol testing, through a full lipid panel, is a vital tool for assessing cardiovascular risk and guiding heart health management, particularly in younger and middle-aged adults. A lipid panel measures levels of total cholesterol, low-density lipoprotein, LDL or bad cholesterol, high-density lipoprotein, HDL or good cholesterol, and triglycerides, providing a snapshot of your heart disease risk. However, for women over 70, the practice of ordering full lipid panels at every doctor's visit, sometimes multiple times a year, can be excessive and potentially counterproductive, especially if their cholesterol levels are stable and their treatment plan hasn't changed. The overuse of frequent lipid testing in older adults stems from a well-intentioned but sometimes misguided belief that more testing equals better care. In reality, for women over 70 with stable cholesterol levels and no recent changes in medications or health status, frequent lipid panels rarely provide new information that alters their treatment plan. Cholesterol levels naturally fluctuate from day to day due to factors like diet, stress, or even the time of day the test is taken. These minor variations can lead to unnecessary concern or prompt clinicians to adjust medications, such as statins, when no change is warranted. For example, a slight uptick in LDL cholesterol might lead to an increased statin dose, even if the change is within the normal range of variation and doesn't reflect a true increase in cardiovascular risk. The risks of over-testing and over-treating cholesterol in older adults are significant. Statins, while effective for many, can cause side effects like muscle pain, fatigue, liver dysfunction, and, in rare cases, cognitive impairment or an increased risk of diabetes. In older women, these side effects can be particularly problematic, as they may exacerbate existing issues like frailty, reduced muscle mass, or balance problems, increasing the risk of falls, a major cause of injury and disability in seniors. Aggressive cholesterol lowering may also have diminishing returns in older adults, particularly those with limited life expectancy or multiple chronic conditions, where the benefits of preventing a heart attack or stroke may not outweigh the risks of medication side effects. Moreover, frequent testing can contribute to medicalization of aging, where normal variations in health metrics are treated as problems requiring intervention. This can lead to a cycle of anxiety, additional testing, and potentially unnecessary treatments, all of which can diminish quality of life. For example, a patient might feel pressured to chase perfect cholesterol numbers, even when their overall cardiovascular risk is well managed through lifestyle and stable medication. Instead of routine lipid panels at every visit, women over 70 should focus on a holistic approach to heart health. This includes maintaining a heart-healthy diet rich in fruits, vegetables, whole grains, and lean proteins, while limiting saturated fats and processed foods. Regular, gentle exercise, such as walking, swimming, or yoga, can improve cardiovascular fitness and overall well-being without the risks of aggressive medical interventions. Blood pressure and blood sugar control are also critical, as these factors often play a larger role in cardiovascular risk than cholesterol alone in older adults. If lipid testing is needed, it should be guided by specific indications, such as a change in health status, new symptoms, e.g., chest pain or shortness of breath, or adjustments to medications. A discussion with your doctor about your overall cardiovascular risk profile, considering factors like family history, smoking status, and other comorbidities, can help determine the appropriate frequency of testing, which may be every few years rather than every visit. 6. Thyroid testing without symptoms. Thyroid disorders, such as hypothyroidism, underactive thyroid, or hyperthyroidism, overactive thyroid, are relatively common in older adults, particularly women, due to age-related changes in thyroid function and the higher prevalence of autoimmune conditions like Hashimoto's thyroiditis. However, routine thyroid testing, often included in broad blood panels ordered during annual checkups, can lead to overdiagnosis and overtreatment in women over 70, especially when no symptoms are present. Thyroid function is typically assessed by measuring levels of thyroid-stimulating hormone, TSH, and, in some cases, free thyroxine, T4, or triiodothyronine, T3. These tests are valuable when investigating symptoms like fatigue, weight gain or loss, cold or heat intolerance, mood changes, or hair loss, which may indicate a thyroid disorder. However, in the absence of symptoms, routine thyroid testing often detects subclinical conditions, such as subclinical hypothyroidism, mildly elevated TSH with normal T4, or subclinical hyperthyroidism, mildly suppressed TSH with normal T4 and T3, where the clinical significance is unclear. The problem with treating subclinical thyroid conditions in older adults is that the benefits are often minimal, while the risks are substantial. For example, treating subclinical hypothyroidism with thyroid hormone replacement, e.g., levothyroxine, may not improve quality of life or prevent complications in asymptomatic patients. However, it can lead to side effects like increased heart rate, anxiety, insomnia, or bone loss, which is particularly concerning for older women at risk of osteoporosis. Similarly, treating subclinical hyperthyroidism can increase the risk of atrial fibrillation, a serious heart rhythm disorder that raises the risk of stroke and heart failure, especially in seniors. Studies, such as those published in the Journal of the American Medical Association, JAMA, have shown that treating subclinical thyroid dysfunction in older adults often does not improve outcomes like cardiovascular health or cognitive function, yet it exposes patients to these risks. Routine thyroid testing without symptoms can also lead to a phenomenon known as diagnostic creep, where minor lab abnormalities are treated as diseases, even when they're unlikely to cause harm. This can create unnecessary worry and burden patients with lifelong medication regimens that may not be needed. For example, a slightly elevated TSH level might be a normal variation in an older adult, yet it could trigger a prescription for thyroid hormone, leading to regular monitoring and potential side effects. The better approach is to reserve thyroid testing for situations where symptoms or clinical indications suggest a problem. Women over 70 should be vigilant for signs of thyroid dysfunction, such as unexplained fatigue, significant weight changes, heart palpitations, or changes in mood or cognition, and report these to their healthcare provider. A thorough history and physical exam can help determine whether testing is warranted. If you feel well and have no symptoms, there's no need to push for routine thyroid screening as part of a standard blood panel. Instead, focus on maintaining overall health through a balanced diet, adequate sleep, and regular medical checkups to address any new or concerning symptoms promptly. 7. Cancer screenings beyond guidelines. Cancer screening tests, such as mammograms for breast cancer, colonoscopies for colorectal cancer, and low-dose CT scans for lung cancer, have undoubtedly saved lives by detecting cancers early when they are most treatable. However, for women over 70, continuing these screenings indefinitely or beyond evidence-based guidelines can lead to more harm than benefit, particularly when life expectancy is limited or other health conditions take precedence. Screening guidelines are designed with specific age and health status cutoffs because the risks and benefits of screening change with age. For example, the USPSTF recommends stopping routine mammography at age 75 for women with average risk, as the likelihood of detecting a cancer that would impact life expectancy decreases, while the risks of overdiagnosis and overtreatment increase. Similarly, colorectal cancer screening via colonoscopy is generally not recommended after age 75, particularly for those with no history of precancerous polyps or other risk factors. Lung cancer screening with low-dose CT is typically reserved for heavy smokers and stops at age 80 or after 15 years of smoking cessation. The risks of continuing cancer screenings beyond these guidelines are multifaceted. Colonoscopy, for instance, requires bowel preparation, sedation, and carries risks like bowel perforation, bleeding, or adverse reactions to anesthesia. These risks are higher in older adults due to thinner intestinal walls and comorbidities. Mammograms may detect slow-growing breast cancers or ductal carcinoma in situ, CIS, which may never progress to invasive cancer during a woman's lifetime. However, an abnormal finding often leads to biopsies, surgery, or radiation, which can cause pain, infection, or emotional distress without improving survival. Lung cancer screening can similarly lead to false positives, prompting invasive follow-ups like bronchoscopy or surgery, which carry significant risks in older adults with reduced physiological reserve. Overdiagnosis is a key concern in older adults. This occurs when a screening test detects a cancer that would not have caused symptoms or death during the patient's lifetime. Treating these cancers exposes women to the physical and emotional burdens of cancer treatment without providing meaningful benefits. Additionally, false positive results, where a test suggests cancer that isn't present, can lead to anxiety, additional testing, and unnecessary procedures. For women with limited life expectancy due to other health conditions, such as heart disease or dementia, the focus should shift from aggressive screening to optimizing quality of life and managing existing conditions. The decision to continue or stop cancer screenings after 70 should be individualized, based on a woman's overall health, life expectancy, and preferences. A frank discussion with your healthcare provider can help weigh the risks and benefits. For example, a healthy 72-year-old woman with a family history of breast cancer might choose to continue mammograms for a few more years, while an 80-year-old with advanced heart disease might opt to forego further colonoscopies. Shared decision-making ensures that screening aligns with your values and health goals, allowing you to focus on preventive measures that enhance well-being, such as maintaining mobility, mental health, and social engagement. If you are still watching this video and finding these lessons useful, please comment number 3 below to let me know that you are still watching this video with me. Thank you for your valuable time. 8. Vitamin and mineral panels without deficiency signs. Comprehensive blood tests to measure levels of vitamins and minerals, such as vitamin D, vitamin B12, iron, or calcium, may seem like a proactive way to ensure optimal health. However, for women over 70, ordering these panels routinely without specific symptoms or medical indications is often unnecessary and can lead to harm through overdiagnosis and overtreatment. The appeal of vitamin and mineral testing lies in the assumption that identifying and correcting deficiencies will prevent health problems. While deficiencies can indeed cause issues, e.g., vitamin B12 deficiency leading to fatigue or neurological symptoms, or iron deficiency causing anemia, testing everyone without symptoms is unlikely to yield actionable results. Many factors influence blood levels of vitamins and minerals, including diet, medications, and chronic conditions, and minor deviations from the normal range are often clinically insignificant in asymptomatic individuals. For example, a slightly low vitamin D level in someone with no symptoms of deficiency, e.g., bone pain or muscle weakness, may not require supplementation, especially if they have adequate sun exposure or dietary intake. The risks of routine vitamin and mineral testing stem from the tendency to overtreat borderline or minor abnormalities. For instance, excessive supplementation with vitamin A can lead to toxicity, causing symptoms like liver damage, bone pain, or neurological issues. High doses of iron supplements, taken without evidence of deficiency, can increase the risk of infections, gastrointestinal distress, or even heart disease in some cases. Calcium supplements, often prescribed to older women to prevent osteoporosis, have been linked to an increased risk of kidney stones and cardiovascular events when taken in excess. Similarly, overcorrecting vitamin D levels can lead to hypercalcemia, high blood calcium, which can cause kidney damage, confusion, or heart rhythm abnormalities. Routine testing also contributes to healthcare costs and patient anxiety. Comprehensive panels are expensive, and abnormal results, even if not clinically significant, can prompt further testing or specialist referrals, adding to the burden on both the patient and the healthcare system. The psychological impact of being labeled with a deficiency can lead to unnecessary worry and a focus on medical interventions rather than lifestyle improvements. The best approach for women over 70 is to focus on a nutrient-rich diet that includes a variety of fruits, vegetables, whole grains, lean proteins, and dairy or fortified alternatives. If a multivitamin is recommended by your doctor, a standard formulation tailored for seniors can help fill minor gaps without the need for extensive testing. Testing for specific deficiencies should be reserved for cases where symptoms or risk factors are present, such as fatigue, numbness, or bruising, which might suggest B12 or folate deficiency, or a medical condition like malabsorption, e.g., celiac disease or gastric bypass surgery, that increases the risk of deficiencies. By prioritizing symptom-driven testing and a balanced approach to nutrition, women can avoid the pitfalls of unnecessary testing and supplementation, focusing instead on sustainable health practices that enhance overall well-being. That's a wrap on uncovering the surprising truth about common health checkups that many women over 70 are told are essential, but can lead to more harm than good. From the confusion of unnecessary PSA tests and the risks of full-body scans to the overdiagnosis from frequent DEXA scans and outdated pap smears, I hope this video has empowered you with the knowledge to make smarter, safer choices for your health. I'm Dr. Emily Carter, and my goal was to not only expose these pitfalls but also arm you with practical, effective alternatives to focus on what truly matters for your well-being. So, I want to hear from you. What's one key lesson you're taking away from this video? Maybe it's challenging a test that doesn't align with your needs, prioritizing symptom-driven care, or embracing lifestyle changes like better nutrition and exercise to support your health. Drop a comment below and share that one thing you've learned and plan to put into practice in your life. I'm excited to read your thoughts and see how you're taking control of your health journey. If you like this video, please leave your comment below, and don't forget to like, share, and subscribe to our YouTube channel for more trusted, actionable health advice to help you thrive at every stage of life.